Hello, everybody. Welcome to today's webinar, COVID-19 Vaccine Hesitance, Conversations with Primary Care. My name is Margaret Howarth-Brockman. I am the Senior Program Manager at the National Collaborating Center for Infectious Diseases, and I will be your moderator today. This webinar is being delivered in English only. NCCID, the National Collaborating Center for Infectious Diseases, is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning and policy. I would like to start today by acknowledging that NCCID is hosted by the University of Manitoba and located on the Treaty 1 original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. NCCID strives to speak the truth about the histories of colonization, and we are committed to active, meaningful reconciliation. There are a couple of housekeeping items. We are running this webinar through Zoom, so if you have any technical problems with the platform, please email us at nccid@umanitoba.ca. After the main presentations for the question and answer session, we will be using the Q&A tab, which you can find on your screen. Please wait until the end of the session to submit your questions for our experts. The recording of this webinar and the presentation slides as they are, actually I think it's just the recording, will be available shortly after the webinar at nccid.ca. So for today we have two speakers. We have with us Dr. Miles Leslie, and I'm going to invite him to put his camera on, as well as Rod. Dr. Leslie is the Associate Director of Research at the School of Public Policy in the University of Calgary. He is a qualitative researcher focused on understanding how policy and quality improvement interventions intersect with clinical front lines. Dr. Leslie's main interest is primary care and the technology, policy, organizational and clinical level reforms that are needed to support the delivery of high quality care. We're also joined by Dr. Rod Vadak, who has a background in anthropology of medicine, completing his master's and PhD degrees at McGill University. His work previously focused on global health security and epidemic preparedness, as well as global health policy and international development. He now works as a research associate at the University of Calgary's School of Public Policy, where he has been researching and responding to the COVID-19 pandemic in Alberta. So with that, I will turn it over to our two speakers, and remember that you will have a chance to ask your questions. The chat function is disabled for attendees, but we will have a few pieces of information posted for your information. Over to you, Dr. Leslie.
Thank you very much. And to everybody who is attending as well, to the team at the NCCID for your time and care putting this together. So we are Nicole, Rod, and Miles from the School of Public Policy at the University of Calgary. And probably a bit of an odd handle to be seeing as you're attending a public health-oriented event about vaccine hesitancy. What's policy got to do with that? Well, we're embedded inside a school that does an awful lot of different work, and some of that work has been on exactly that topic, vaccine hesitancy. We have had the privilege, our team, that's Nicole, Rod, and myself, to be working with primary care folk across Alberta and Canada pretty much since the first case was announced in Alberta. And what I'd like to be able to talk to you today about is a kind of extension of the strange bedfellows that COVID has created. And we're hoping that the relationships, which may have begun as strange ones, continue into the future. Particularly the amount of overlap and coordination that we've seen between public health and primary care in the response. We can speak most knowledgeably about what's been going on here in Alberta, but across the country as well. As you may know, a number of our colleagues in the primary care world were at the forefront of doing community outreach around what at one point in this long history of the pandemic that we've had so far was the largest outbreak in North America at the Cargill meatpacking plant. The way that public health, which is administered by Alberta Health Services, and primary care, which is a series of independent contractors who bill fee-for-service. Well, there are some exceptions, but generally bill fee-for-service to the government. The way that public health and primary care came together to create a community-based response that it culminated most recently. And I think the clinic only shut down about a week ago in a vaccination clinic for the meatpacking plants across the province, is a real beacon for how what might begin as strange bedfellows ought to become a long-term and permanent relationship. What we'd like to talk to you today about is a way of thinking about primary care as an extension of public health, as an opportunity, as probably one of the best opportunities we have to get into individual conversations with people. As you are all well aware, there is an extremely large campaign done at the aggregate level to try to address vaccine hesitancy issues and concerns across the country. But billboards and even social media are not able to talk directly to people and are not able to pivot, as much as the market research may be good, towards what those people are actually thinking and feeling in the moment in the conversation. And so that brings us to our team and to the idea of putting that public health message out through primary care. The title of the talk is about primary care conversations. And this is a talk about how to have better, we hope, vaccine hesitancy conversations, or conversations that improve vaccine confidence on the flip side in the primary care world. So how does a team of policy researchers end up in the primary care space? Well, we received, on the day that the first case in Alberta was announced, funding under the COVID Rapid Response program. That funding led us into some action research, which is to say research that immediately tries to make itself, we shortened the KT cycle, shall we say, of immediate worth and value to the people in the field who were trying to mount the response to the pandemic. And the official story that we went into the field with was that we were following the policy response to see how it was actually being implemented. That was the research that we pitched. And it turned out that one of the spaces where the biggest challenges were coming was in primary care. And as I've already talked about, in Alberta, which is different from, but similar in enough ways to the rest of the country, our primary care is delivered outside of the acute care system, outside of the centralized Alberta Health Services for us, but outside of the health authority. And so a number of gaps were showing themselves as we followed policy and its implementation. One of those gaps was about how to do infection prevention and control in primary care when policies were being written in acute care. Literally, a primary care doctor might turn over a document that had been sent out on how to start reopening after wave 2 and read, when you enter the negative pressure room, and the primary care physician and their team would go, we don't have one of those. So those policy gaps opening up on how things could actually happen in primary care led to a series of interventions that our team put together to help primary care clinics think through, walk through in advance how they were going to respond to these issues. Out of that, and that's not today's story, but out of that come the relationships that allow us to do the work that we do want to talk to you about today. That is work done with primary care physicians and their teams for primary care physicians and their teams to support better vaccine hesitancy conversations. Early in January, our group sat down and we started with the existing sort of popular media coverage and some of the literature on what hesitancy was being thought about and talked about in January, which I realize is very hard to cast our minds back in that weird infinite time loop that is the pandemic. But in January, there were none. There were none available to anybody. And it was just starting to be rolled out that this would be coming. And it occurred to us that we were reading about hesitancy for the very first time. It clearly had been talked about in November and December, but in January, it was starting to get real coverage, real traction in the media. And the dominant narrative around this was about quantity. How much hesitancy did somebody have? And we, as a group, discussed this and said, yes, this is a valid and good way to start the conversation about hesitancy, but it seems like there's something missing. And if we think about the quantity argument and the quantity thinking in the first place, if you have a sort of normal distribution curve, a nice bell, the people here were already calling their primary care physician's office and saying, I want the vaccine yesterday. And they would be people who you would describe as having almost none or zero hesitancy. You would go through the curve and end up over here. And the people on this side would say, I will never get the vaccine. I feel that it is wrong in ways that I cannot even begin to describe to you. It might have a chip in it that might track me. And this would be an infinite amount of hesitancy over here. Somewhere in the middle of this curve is a group of people who might be sitting on the fence and that we might be able to more effectively have a conversation with and move towards being vaccinated. Effective and a good place to start thinking about the problem. But we, as a team, said, isn't there something beyond the quantity issue? Isn't there something also in the quality of how people are thinking about this? Isn't that at least, if maybe not more important, to understand the quality of someone's hesitations as opposed to just the amount that they might have? And that led us to doing the research that I will talk fairly quickly through today and show you the results of, which are a guide for primary care physicians to have better conversations. So we went off into the field to try to identify what the hesitancies were, where they were coming from, the quality of those hesitancies, not just how much was, but what it came from. We began speaking with family physicians in Alberta and eventually branched out into a number of other provinces, trying to validate a typology, if you will, of hesitancy origins. Where was hesitancy coming from? Because it struck us, and it turned out as we were speaking with the family physicians that it struck them too, that you couldn't bring the same material to each one of these discussions. Each quality, each origin, each type of hesitancy required its own differentiated response. So the first phase of our research was to go out and speak with physicians about what they were actually seeing. What kind of objections or hesitancy were people expressing in clinic in January, in February, and then since the rollout, have people said that they're reacting differently to the second dose. So we have an emerging set of hesitancies as the vaccination program has gone forward. Having completed that round of research and worked with the physicians to come up with a way that we could present it so that they understood it and it was sort of made an intuitive sense. And I'm always worried about the word intuitive because the intuition here is obviously a product of professionalism and professional experience, but that it made intuitive sense to them that we would present this typology, this set of origins in a specific way. They agreed. And then we went back into the field to do role play interviews. These role play interviews where our team would take on each one of the types of hesitancy, expressing it in a clinical conversation, and ask the family physician to then respond with how they were dealing with this kind of hesitancy. In a number of instances, people were completely stymied, as we would expect them to be, because when someone comes at you with something that is either anathema to how you think about the world, or maybe even directly questions your credibility and your training, it's often very difficult. Your mind goes a dark purple and you're not able to say anything that's effective in that moment. We didn't just role play and then say, so what do you do with that? We asked them to then think through their responses using a particular framework that is current in the literature, the vaccine hesitancy literature, called motivational interviewing. I'm sure many people are familiar with this. I won't belabor the point, but motivational interviewing looks at where the patient is coming from, their motivations coming into, and then tries to work with motivations, positive ones rather than negative ones, to find a way forward into not necessarily getting vaccinated right here, right now, but to thinking more about it. I didn't mention before that we chose primary care not just because we had relationships in that space already, and that there was so much good work going on with public health, but also because it struck us that in getting to the qualities and dealing with the qualities of hesitancy that people have, it was important to have longitudinal conversations, longitudinal trusting conversations. And this was exactly what primary care practice at its best offered. was the opportunity to revisit a topic, and revisit a topic with someone who had not only medical expertise, but was seen as a trusted expert in areas of health and well-being. Sort of the absolute inverse of a billboard that says you should get vaccinated. This is someone who you do know, you do trust, and you have a more than just driving the car by it relationship with. We then took the second phase of research, which was the one where we extracted what was the motivational interviewing principles that people were using effectively to counter or work with alongside their patients, the various forms of hesitancy, and built the guide that you are seeing a sort of tease version of on the screen right now. I will wrap up my rant here with a few quick take-homes for not just primary care physicians, but also public health specialists who are engaging in these conversations. Our research, in accordance with the motivational interviewing principles, strongly suggests that one of the key things that you need to do when you get into these conversations is adjust your expectations. Not only are we setting aside the information deficit model of, well, I'll simply provide facts in a pamphlet and somehow that will break down this concern, this objection, this fear. We're not only setting that aside, but we're rejigging our goals. So that the goal of the conversation isn't, yes, I will have this done now. It's, I will continue to talk with you and I may think more about this. The goal is contemplation rather than action, and action may come from that. A second major take home from the research that is concordant again with the motivational interviewing principles is that you are not a salesperson, you are an ally. To enact ally is not to try to force or sell. It is to be alongside and understand and have empathy for. To offer someone that, yes, this is a choice you can make and I will respect the decision one way or the other, which is a hard thing to do, particularly in a clinical situation for a family practitioner who may be on their 20th patient of the day. How do you do that at 3:30 in the afternoon? Hanging a question like that out there, I would like to stop talking. You're probably not particularly interested in hearing it anymore anyways, and pass you over to one of my colleagues, Rod, who will do a tour of what was produced out of those two phases of research. The first one identifying a typology of origins or qualities of hesitancy, and the second one identifying specific motivational interviewing techniques for working with a patient to get to the other side, to get towards contemplation.
Sure. Thank you, Miles. And yeah, I'll take over screen share real quick. So this is the site, which you have seen the preview for there. So this is what you will find at vhguide.ca. My intention is not to, handhold you through the site and go through all the content here. There's plenty of content to go through, which I assume that some of you will do on your own free time. And the site is meant to be explored on your own terms. So this isn't so much of a demo or a tutorial as it is to just discuss a little bit about how we structured the site and kind of provide our thinking behind how we harmonize the content that we gathered in our research and really came at it with a particular kind of design philosophy here to present that content in a usable and functional way. So the idea behind the site is really to, we really thought through this in terms of two use cases that we knew would be sort of the most predominant. On the one hand, most likely a sort of asynchronous use case for clinicians, primary care clinicians, who would browse this outside of an individual patient encounter. So we're not so concerned with having this kind of respond in real time to somebody who's on the phone with a patient if they're doing a virtual consult and saying, well, what do I say next if this patient thinks that vaccines are going to interact with their DNA or something. We really thought of this in terms of those aggregate kind of, I've been seeing this patient 4, 5, 6 times, and I'm really trying to think through a new strategy for how to approach that conversation. And that goes for clinicians of not just physicians, but it also goes for people in the public, right? Talking to family members and others. So again, as part of that validation strategy, it was who are you seeing the most and the most commonly? So there's really that asynchronous use case of I'm just exploring this kind of, before I go to bed, or I'm exploring it, after I have that really difficult conversation. On the other side, we did see people talking about a use case where they would use it synchronously in a patient encounter. So we really tried to make it navigable and really present information in a way that was not overwhelming, so that it would unfold slowly as you continue to browse. So I'll just quickly walk you through and demo kind of how we laid this out. Here we have our splash screen. These hesitancy types are the things that we validated in that first phase that Miles was talking about. And it took quite a while for us to really figure out how are we going to organize these different types and present them. And it is a consistently evolving project to make sure that these stay current and really represent the wide gamut of those qualities of vaccine hesitancy that we have seen encountered. Our aim here in this particular format here with specific vaccine hesitancies, which has the most content, as you would expect, was to present the most specific and new information that clinicians would need to use for COVID-19 at the very top. And the stuff that perhaps they're a little bit more familiar with a little bit further down. So we know that primary care clinicians and physicians with their patients have been dealing with fears of needles for a long time, right? With sort of blood work and other vaccines and other sort of shots. Physicians know about the resources and how to consult and have those conversations with patients that may not feel comfortable with needles. What is new about the sort of COVID-19 situation are concerns about the science, concerns about, does mRNA affect DNA? What about fertility and the impact on fertility? What about the side effects of these particular vaccines? So we really wanted to make the most specific and new information appear kind of at the top here. And of course, things like mRNA vaccines affecting DNA, the potential for that, the concern about that was something that we heard called out many, many times. So we made a specific hesitancy type about that. The idea here is to present an overview page for each one of these hesitancy types that really gives a sense of a differential diagnosis. Are you talking to this kind of person? In this case, it's quite clear. This is what this person would likely say. But also pragmatic advice that distilled some of the advice that we had seen from those physicians in those role play sessions, different aggregations of strategies, if you will, things to consider, what to do, maybe different approaches. And then really a take-home piece of language that's empowering language for clinicians to really showcase that your recommendations can make the difference here for these patients. Behind this is really the heart of the tool, this advice area. And as Miles said, we really took that inspiration from motivational interviewing, which has that sort of groundedness and applicability to vaccine hesitancy conversations. And we adapted motivational interviewing to create our own sort of steps, 4.5 steps, if you will, which we put under the acronym EASE. And those steps are engage with open questions, affirm and reflectively listen, ask for permission, then share information or knowledge, and evoke and evaluate options. And this is kind of our cycle of how to structure these conversations. It's a sort of, as a cycle, you can hop in and out at any point. It's not meant to be sort of comprehensive or linear in any way. It's just a sort of way that we found that helped us structure this content. And so we thought that it would help structure those conversations as well. And so as we organized it further that way, we really wanted to create, again, a top level that wasn't overwhelming with text, but allowed you to dive in even further. And so once you're fully in these steps, we have all of our sort of quotes that we have pulled out from these individual role play sessions meant for these particular vaccine hesitancy types. Again, that sort of accordion of progressively more information as you explore. We really wanted to keep some of these really longer, full, rich stories, these metaphors and other things that people used. In this case, a chef analogy to explain how the mRNA vaccines work. It was a lovely sort of analogy. So we kept these full things in here, but again, hidden behind a few clicks so that people aren't overwhelmed with information. And then we have a resources tab for each of these particular hesitancy types. These resources tabs are always going to be under construction, but they are certainly under construction now in the sense that we are working with our partners and collaborators to continue to align these resources with the best kind of available evidence and most useful and practical things that are out there. So this space for sure is evolving, but we wanted to make sure that we would have resources available for practitioners that were organized in the way that we had gone through and done these hesitancy types. So just to kind of rewind back to the structure of this and the way that we really went about organizing this content and thinking it through, we took great care to make sure that with the idea that this could potentially be patient-facing, we wanted this language to be sensitized and non-stigmatizing. And that was a little bit more difficult than it seemed from the outset. Not in the sense that we were out to get patients or call them out or something, but it is difficult when you are creating recognizable categories of hesitancy types that work for physicians but don't stigmatize patients. And so this is really in line with trauma-informed care, that we wanted to make sure that if a physician or a clinician turned a screen around or their mobile phone around, as it were, and showed a patient, well, let's look at this together, that there wouldn't be a kind of a sense of calling anybody out here. This would really be a sensitive space that would be applicable to both physician and patient without kind of a vulnerable sense here. So, this is a tricky space. Calling somebody a conspiracy theorist may not be the greatest thing to do, but in practice, for physicians to recognize these categories, they needed to be very legible. So we worked hard to make sure that these categories were, again, trauma-informed and sensitized for patients as well. One of the areas that we continue to work on with that sort of trauma-informed approach is our trauma section. So we have a section that is broken up into sort of individual or personal negative experiences with healthcare systems, but then also community, group, or historical traumas. And this area of the page is really one that we are planning on growing as we strengthen our collaborations with clinicians and even direct members of vulnerable populations and communities to make sure that we are informing the advice sections here as sensitively as possible and as effectively as possible. We want to make sure that advice, again, really carries over as stuff that is about better conversations, about really growing that kind of relationship between a provider and their patient, and having a provider really work toward a better understanding of the patient's hesitancy and the things that may change their approach to their hesitant thinking and build confidence in those vaccines. So that's been a real key kind of approach here as we continue. This undifferentiated vaccine hesitancy space is really a place where, we had a lot of really, really good advice that was coming out of these conversations. And in some cases, it was applicable to all of the different sort of hesitancy types that we had formulated. So we sort of put this is like the all category, if you will. But we also were hearing from people that some of the providers may have not even had that conversation yet to really understand the specific hesitancy that their patient had. And so we wanted to make sure that, even if you haven't had that conversation, there's still stuff in here that's going to be relevant to help you structure those conversations, to help you approach those conversations and make sense of them. Finally, we have a clinical pearls section. And this section is really meant to capture the advice that we were getting that's really clinician to clinician advice, how to have these conversations, how to structure these conversations. So these are less kind of direct strategies to use and more kind of approaches and reflections on practice. And so there's, again, these sections are always changing and building. We're hoping to gather more all the time. But we really got some great ideas and affirming snippets in here from practitioners who, empowering things to show that, clinicians aren't going through this alone. Like these are difficult conversations. They're taking up a large amount of clinicians' time right now. So to hear that other clinicians are maybe losing their temper or having a hard time keeping their temper, things that they've done to try to make themselves and their patients feel better when they're having these conversations. We really wanted to capture those things to make sure that clinicians feel like this is again, a peer-driven space and a space that really is empowering for them. So again, an evolving space with content. We hope to gather more across the next months and update this in additional releases. But this was an important space for us to keep these kinds of advice that didn't fit into a particular hesitancy type. And I think that's generally, our about page has a little bit of that overview of our e-steps just broken out for reference. But other than that, I think that's kind of the design philosophy here and the way that we've organized our content. So I think with that, I'll turn it back over to you, Miles, to wrap up, and we can take some questions.
Excellent. Thanks so much, Rod. I'm hoping people have a sense that you can go here, www.vhguide.ca. There are no padlocks on the outside of this. This is an intentional move on our part. We are aware that there are people who are vehemently against vaccination. And we were counseled at one point, well, you should probably make this a password protected place because we said, no, this is open to anybody. Yes, it's clinically focused, and I would be very surprised if an awful lot of people other than clinicians read through it. But there's nothing nefarious in here. We have nothing to hide. And if you take the time to read it, you'll find out that this is not about being a salesman. As I said, one of those take homes from before is this is not about selling anything. This is about improving conversations and respecting the person that you're talking to. It's a fellow citizen, it's a patient who has a different set of concerns than you do. Where are you going to take those? I'm hoping that people have, in listening to myself and watching along with Rod, a sense about how this is very micro-oriented. For a public health and infectious diseases crowd, this is going to be very like, wow, that's super in the weeds. But that you can see that here is something to help in that growing relationship between primary care and public health, something to bolster the capacity of the health system writ large, including primary care, rather than just being acute care focused, accomplish those goals. So if we go back to the quantity thinking from the very beginning, that we can take all sorts of people and move them towards contemplation and hopefully action on this by supporting better conversations in this way. I will not talk any further and I'm happy to take questions. Should there be any?
Thank you both, Miles and Rod, for that very interesting presentation. I would like to invite our webinar participants, attendees, to enter any questions you may have in the Q&A tab that is available to you. While we wait for them, I'll just start with some questions that had already come in. Can you tell us a bit about whether and how your guide has incorporated aspects of cultural safety and cultural respect in the conversations primary care providers will have?
Yes. So we chose in this presentation and generally as we talk about it to talk mostly about motivational interviewing as a rubric for how we conducted the research and then how we've analyzed the results of that second phase of research. Inherent in the motivational interviewing approach is the concept of trauma-informed care, that this is culturally sensitive care, that this is patient-centric care. So we've not used those terms specifically. We take them to be sort of umbrellaed underneath motivational interviewing in that it is a respectful rather than top-down approach to having these conversations. We have engaged with, and we're seeking extra funding to be able to do more of this, but we have, I would say, like initial engagement with both First Nations and immigrant populations to be able to talk through what's been said. So in case the question, and I don't want to assume what the question was embedding, but in case the question embedded the idea that we somehow went out and talked to some docs, wrote down what they said, and then stuck it in the guide, everything's been filtered through motivational interviewing. Everything's been filtered through the idea of trauma-informed care. So that if somebody was pressing ahead with culturally insensitive and probably ultimately quite unsuccessful, because if you are culturally insensitive, you're no longer trusted by the person you're with, you're no longer an ally of theirs. Why would they take your counsel on vaccine seriously at all? If somebody has pressed ahead with that, it has not showed up in the guide. So hopefully that's an answer to the question. It is certainly at the core of our existence as a research team. I'm a sociologist, critical scholar by trade to start with, and that's sort of where we started our game on this.
Okay, thank you. One question that's come up just now, first of all, to say thank you and fantastic work to both of you. Any plans to adapt the guide, specifically looking at pregnancy and breastfeeding?
So again, an application going in for extension funding. Think of this with your public health hat on as being the general population version. It's got some material for vulnerable and marginalized populations. As Rod showed you, we have a group trauma section. That group trauma has some specific First Nations, some specific recent immigrant material inside it, but it does not necessarily have enough of these things. I apologize. I've just completely dropped the question in my head. Can you ask it again?
The question was about pregnancy and breastfeeding as well. Are there aspects that address that, or is that part of the plan?
Under reproductive concerns, which was under science and safety, and then when Rod was showing you, it went down and there was one under reproductive. It's almost entirely about conception in there. It's not about perinatal issues. As a result, and that's where I was going with that other rant, sorry, I got lost on my own tail there. We're seeking extra funding to be able to go off and get specific material like that. We would like to be able to go into those areas in more depth. There's not a lot of coverage on it for the moment. We're also hoping, because it is a living tool, it's not like we didn't just publish this and then go, okay, you heard Rod say multiple times, this is being updated. That's not the sort of like grant language, like we want to update it. There's a feedback form. Send us stuff. It's going to be run through the motivational interviewing principles and it will go up. This is crowdsourced expertise. We don't own any of this. This is about the practitioners saying, hey, this is what I'm doing and it's helping. That metaphor, the long screen about the chef who comes into your house and cooks a meal and then leaves afterwards to explain how mRNA works, is something that we want more of. Like, tell us the stuff that's working. Because that's what people are looking for. They're looking for something that's helpful in their conversations. So the short answer is no, we do not for the moment have anything specific to breastfeeding. The nuanced answer is we've got stuff around reproduction, and the longest answer is we're looking for more material. Please send it.
Yeah, I would just piggyback on that and just say, and I think this is maybe touching on the next question that's open here, is again, Miles stressing that the tool is a living space. And so the idea is to really, right now, we've set up the skeleton of a tool that can absorb a lot of content. And we want to continue absorbing that content, but we know that content really comes from us having conversations with practitioners that are engaged in those conversations. So conversations about conversations, but really figuring out what is working, what kinds of concerns really are paramount. And we have heard things like the need for this in pediatrics, and potentially to pivot this kind of tool to other applications of vaccine hesitancy, which we will address here in a second, I think.
Thanks, Rod. Yeah, so that is another posted question, which is along the lines of one that we received earlier, was how can this be adapted to other hesitancy questions when it comes to vaccines? If we're looking ahead to an HIV vaccine someday, or HPV, they were already a challenge before COVID. So any thought on how this knowledge can be transferred or incorporated, it sounds like.
I think, yeah, I don't want to steal Rod's thunder because he's said it already. The idea is that we've built something here that it's really easy to adhere content to. When Rod was walking you through and showing you that the content that inside the differential diagnosis tree, the content has been ordered in a way that puts fear of needles at the bottom, because that's garden variety stuff for a family practitioner, versus science and safety concerns, which are COVID specific. This tool, or at least the skeleton of it, properly re-researched, which is to say, send out the qualitative team to be able to do the interviews, to be able to then run it through motivational interviewing during the interview and in the analysis afterwards, can be repopulated with whatever's working for whatever vaccine we're talking about. And when it's repopulated, it's reordered. It's not, presumably fear of needles remains through everything because you got to get stuck. But beyond that, what actually applies here? Where are the big resistances inside HIV or whatever else we're talking about? And it can be retasked for that, but the architecture is in place.
Yeah, and sorry, just to add again to that, I think the important part of now kind of that we've had a chance to launch the tool and look back and really start to consolidate our thinking around the process of getting to where we got to launch, and thinking about repurposing it for like people like patient partners or the general public or different vaccines or different even health issues. We've really kind of seen how tightly woven the processes that Miles was describing in the beginning were to the delivery of the content in the end. So the website really, and the structure that we have, it's not just that the website is programmed and so we can add new categories. It's that those categories really were tied to that sort of two-step process that we went through of validating the typology and iterating those categories all the time in conversation with practitioners who are seeing this. And then from there, going into those role play sessions with those practitioners and finding what worked and then workshopping that through another process. And so is this kind of content delivery strategy that then fed into the tool. And that is what is modular. That is what we can then use for other types of hesitancies or other types of medical issues, other vaccines, other populations of people who are having these conversations. So that's what's promising and exciting. But certainly we need the sort of collaboration of partners in the community to do that. So.
Well, thank you both. And today's topic is about conversations on vaccine hesitancy. So we'll stick to the questions that are related to today's webinar. And thinking about the modular versions that you're thinking of and the sustainability, what about opportunities to include nurses who do primary care? And we also know that many pharmacists provide vaccines. They provide a site that patients can come to because it's close to home.
So this is, again, www.vhguide.ca, available freely to all. If you are a clinician and you happen to dispense drugs, or you happen to be an NP, or you happen to be a family doc, or you happen to be a medical office assistant at a family doc's office, this is available to you. There's no padlocks on the outside of it. To Eliana Castillo's question, the idea that a mom will listen to a mom, yes. I hear you, and I hear where this is headed. We're having just thrown the gates open and say, if you're in the healthcare business, come on in. The way the tool's been developed, like the content that somebody would find in there right now, is probably not terribly helpful in a mom-to-mom trusted conversation. I agree with you completely that moms trust moms, just like people from the Rotary Club trust other people from the Rotary Club. There are ways that this needs to be thought about and readapted to a more lay-based setting. For now, this is mostly about the question that Margaret's just posed, which is, this is about putting it in the hands of as many medical practitioners as are willing and as who have found themselves thrust into the unanticipated role of being a vaccine counselor. Now, I know a lot of us have found ourselves there in the last little while, but not all of us come with the same credentials and trust platform. And that's the difference, where the moms and the Rotary Club members are different from how this tool has been built, is that anybody, yes, nurses working in primary care, yes, NPs, yes, anybody who comes with a longitudinal relationship, and I think that might be a bit more of a challenge for some pharmacists practicing in some circumstances, but it's certainly not a barrier to entry that cuts everything off. But if you've got a longitudinal relationship and you are a trusted source of medical advice, then the way of thinking about things that's embedded in this tool, which is motivational interviewing, which is trauma-informed care, which is culturally sensitive, patient-centric care, the way of thinking is helpful to you, and the content is also helpful to you because you come with that trust platform built in. Extending it out into the lay world is another challenge and another step to take. And we'd have to think differently about it, because the mom in the mom relationship, the mom to mom dyad has trust and whatever else, but probably deploys different stories, probably says different things. I don't know that that's true, but it's a research question we'd have to pursue. So I hope that that's helpful to answer Eliana's and the question that Margaret's brought forward as well.
Great, thank you. Just going back to the genesis of your work, your direct conversations with primary care clinicians, what did they say is the most challenging about the conversations they have? And does that include just getting that conversation started to talk about the COVID vaccines?
No, so work of colleagues of ours at the Alberta Children's Hospital produced Protect, which was a tool, a clinical bedside tool to start the conversation. And the PR in Protect was proactively start the conversation. And most people were finding that they could do so, right? Hey, Margaret, you're in today for that cough that you've got. And I just wanted to check, now that we're at the end of the appointment, we've addressed most of your concerns. Have you been vaccinated? That doesn't seem to be the sticking point. I think, and so there's no systematicness to this. Please don't hold me to, well, this is definitely the number one cause. And I would invite both Rod and Nicole to maybe come up with their own version of what they think the number one cause is. But the number one cause of consternation, if I was to pick one out of all of the conversations that we had with family doctors, is probably about high-level mixed messaging. Everybody understands that the science is in evolution. Everybody understands that decision-making is being made in conditions of radical uncertainty. But the people who are thrust into the unanticipated role of being vaccine counselors, one of the hardest things to try to clear away to get to being an ally and having a conversation is the fact that people will walk into their clinics and say, these bozos have no idea what they're talking about. They just say one thing and then 6 weeks later they say something else, and there's nothing to be trusted here. What do you do with that? How do you, that's been, I would say, from our data, and I asked my colleagues to reflect and say something different, but I would say that that's some of the biggest challenges that the family docs that we talk to are encountering, is how to take the inbound. It's not aggression towards the doctor themselves, it's towards a public health system, which, let's take all the caveats and just set them aside. A public health system that, if you're sitting in the audience watching it, is countermanding itself at different levels. And what do you do with that? I think that would be where I would put my finger on some of the hardest stuff that they're currently dealing with. Getting the science, straight and saying, well, there's evidence for this, or the evidence is emerging about that, or here's how I think about it. But that all seems to be okay. And starting the conversation seems to be okay. But clearing aside big issues that are raised when messages become mixed seems to be an issue for me. Is that, Rod, Nicole, do you guys concur?
Yeah, I would definitely say it was a big thing that was repeated in multiple instances. I know that, speaking to my own family physician about this tool and asking her, are you having these conversations? How difficult is it? Would a tool be helpful? She was really talking about, at this point, physicians are starting to get, family docs, at least in Alberta, and I know in other provinces as well, are starting to get sort of tallies of how much of their panel is vaccinated, and then they're getting a sort of report of which of their panel are not. And within that small proportion, say 10% of their panels that aren't, the amount of time that they're having to spend in these conversations is really, I think, overwhelming them, because these are complex and nuanced conversations that rely on, again, a long history of medical care to a patient, a relationship to that patient, and a really complex evolving space of, again, changing guidance, changing understanding, changing need for vaccination. So even with the tools content, when we were going through it just prior to release, a lot of the content was really focused on, well, of course you want to get vaccinated because we need to lift restrictions. And so it's like, how are you tailoring your message for really understanding the benefits of vaccination when people are saying, well, it's not going to impact me and I don't want to do it. And so I know that disproportionate amount of time and mental energy and how taxing that can be on these providers that are spending so much time away from other complex issues that their patients have. And it's not to say that the choice to vaccinate is not an important, complex issue that deserves time and attention. It needs it. And that's the difficulty, is that it creates that kind of strain on a provider to then say, well, I really need to spend the time with this patient to see if they can get to that decision-making point, but I also need to tend to my other patients. So I think that was a real moment where that's, I think, another goal of the tool, is to help take some of that cognitive load off of a physician who is having to come up with their own strategies and just think through, everybody's coming up with different acronyms or whatever, but at the end, hopefully these mnemonics are actually helpful of saying, okay, ease or protect or whatever it is. What step am I on? What can I do next? Oh, here's a strategy. I can just go fall back on that one and test it. Oh, it doesn't work. I'll use another one. Here's another one from the tool. So that's really, it's just taking the cognitive load off and hopefully some of the emotional load off too. Yeah.
Okay, thanks. I mean, very much trying to work through this infodemic. Sorry, Nicole, go ahead.
No problem at all. I just wanted to kind of embroider around the edges of what Rod was saying. I think something that we've seen quite a bit of is, medical professionals doing what they do best, which is sticking to the data and the facts. But sometimes that doesn't really resonate with people. As soon as you throw out words like cytoplasm and you start talking about, the mechanics of how cells work, you've lost the patient at that point, depending on what their science and health literacy level is. So I think kind of approaching these conversations through motivational interviewing, as opposed to kind of this information deficit model, which has been kind of the status quo up till this point, is really kind of that changing point in helping physicians approach conversations from more of that human one-to-one kind of approach, as opposed to the science approach, if that makes sense.
Does indeed. Thanks. Just a note to our audience members, we have a couple of minutes left for any questions that you may have. And in the meantime, I'll ask the last one I had on my list, which is putting on my community health research hat. What plans might you have for evaluating the guide and the work that you've been doing so far? Or is that your next grant?
Who wants to take a swing at that one? Go on, Nicole.
Sure, yeah, I'll take a go at it. Yeah, so that's kind of hopes for the next grant. What we've been doing is talking to folks to help us get basically into the community even further, to recruit primary care clinicians as well as primary care residents to basically do a user test with us and to kind of comment on the usability of the tool, but then also have further conversations about like the content and stuff to that effect, and just seeing if there's really a positive impact on the way that folks are having conversations or thinking about conversations about vaccine hesitancy.
If there are folk in the audience who are clearly the next phase of research program that's being laid out there is, we want to understand the impact of the tool amongst those who are using it. Could it be organized better as partially out of a continuous quality improvement perspective and partially out of okay, so this is an effective thing and we can show by having surveyed enough people who used it that it is. If there are ways, and there are people in the audience or anywhere else that would like to talk to us about this, if there are ways to come up with it had an effect. If we go back to our curve and we were trying to take some people and put them just slightly over to here to show that happened, we'd love to hear about it, and we'd love partners to get into it. But I don't know how. I will make the argument vociferously again that unlike a billboard, which is effective in its own way, but which you drive by and don't have a relationship with, this is a fully interactive, trusted billboard that you can talk to. So this is an incredibly important tool of the public health response to this pandemic. This is public health counseling that's going on. It's not just vaccine counseling that's going on. How we would actually see that we were moving that small, because I don't think anybody it's only grant talk that would be like, and we're going to get everybody vaccinated because we did this. But if we're going to say that we're going to move some of those people that were possibilities over into the yes column, how would we go about that? I don't know what the metrics would look like to make that happen. So we're very open to hearing from folks if they have ideas about how that ought to be done and what we could be following.
Well, thanks very much. And thank you all three for your work and for tackling this issue that's on the line, that fuzzy line between public health and primary care, which is an ongoing area of interest and discourse and work together to integrate new information across the lines. I'd like to thank everybody else for joining us today. We hope the information provided will help you with your practice. And we would like to thank all of our healthcare providers and those working in vaccination programs for your efforts during the COVID-19 pandemic. Please take the time to fill out the short evaluation that will be sent to you after this webinar. Surveys are important for our future planning. And just to remind you, this webinar will be available online at nccid.ca. And there you will also find a link to the podcast that Dr. Miles Leslie did for us some time ago. Thank you all.
Thanks very much.
Thank you.
Thank you.